Good morning, everyone. Can someone reply in the chat box if everyone can hear me? Okay, thank you. Thank you, everyone. Good morning. We will begin in a moment. My name is Effie Battis from the Audacia Foundation. We welcome you today. We wanted to spend some time connecting with home care providers. As many of you know, those of you that are our training partners and have attended our home care training, that has obviously in these circumstances been postponed as we all deal with this crisis. But we did want to identify ways that we can, as a training organization, support you in your needs during this time of crisis. So our purpose today is twofold. One is to share some of the updates that we have learned from Department of Health, CMS, CDC. So that's part of our agenda for today, and we'll go through our learning objectives. And then second is, and more importantly, is to hear from you, all of you. We welcome you through this forum we're using Zoom to either type in your questions. There's a place to chat. You can type your questions, you can send them privately, you can send them to the group, and then we'll also open up the mic. Everyone for now is on mute. We have found that is really the best way to facilitate this forum, is to keep everyone on mute. So we encourage you to use the chat if you have questions during or anything else related that you'd like to share. And then at the end, we'll open up the microphones for anyone that wants to speak, or again, it's fine to just use the chat to share your challenges. We're having frequent discussions with the Department of Health, and we know that you have been in communication with your associations, and it's very important as they are your largest supporters to continue, to rely on the information coming out of them. So we want to again thank you for joining, and I want to say first, we really recognize that this is a crisis that is not just one that affects everyone personally, but professionally, but personally. We are hearing every day from colleagues that are very, very sick, dear friends and individuals that work in long-term care. So we recognize that these are incredibly challenging times on so many levels. And so anything that we can do as an organization to support you, that would be the least that we can do. So with that, I'd like to begin the webinar. We have with us Anne Frisch, who is going to be providing the information today to you. She's, as many of you know her, she's an RN, she is an MBA, she has over 30 years of experience in long-term care, post-acute and home care. And she has helped agencies navigate many of the provider challenges we have faced, especially in New York City, 9/11, Hurricane Sandy, labor strikes. So she's familiar, and it's dear to her heart, some of the challenges that we're all going through right now. And so with that, I'd like to welcome Anne. Thank you.
Thank you, Effie. And if someone could just indicate that you can hear me, I'll proceed.
Yes, we can hear you, Anne.
Okay, perfect. I just want to echo Effie's sentiments to everyone. I know that I know many of you. I've worked in many challenging circumstances over the years, This circumstance, I think we would all agree, by far trumps any other one. And I am most delighted, of course, upset at the same time, that I have the ability to work with an organization like Audacia to help all of you navigate through these very, very trying times. I've taken the opportunity of putting together this presentation with much direction, guidance from my colleagues at Audacia, but also in speaking with many of the providers, representatives from HCA and HCP, as well as the Department of Health. And I'm hoping that by the end of this presentation, we will have all achieved the objectives that have been outlined, which include discussing the most recent DOH, CMS, CDC guidance to home care providers for the management of employees and patients exposed to or with COVID-19. Identifying, of course, with your help, the provider challenges of managing patients and employees with COVID-19. Identify, and again, with your guidance and input, the significant obstacles in maintaining services to patients and how additional resources, if available, could help. I'm hoping that we can share some best practices, maybe little things that make a big difference amongst the providers relative to maintaining essential home care services. And I've also taken the liberty of, at the end of the presentation, providing all of you with many of the credible resources to assist you in managing your staff and patients throughout this pandemic. And I've had the luxury, not presently being responsible for running a home care organization, to do a deep dive into the subject and all the guidance and the resource that's out there. And if the pandemic itself isn't overwhelming, the guidance and the websites certainly are. So I've culled through them, and I've listed a few at the end that I think can serve as a springboard for the vast majority of your questions and concerns. So as we move forward, just in the past week or so, we've seen some of the guidance changed from the DOH in terms of how to prevent the spread. So I wanted to start with this slide because this kind of starts with where we were a week or so ago, and we'll build on that as we move forward. But just in terms of summary, we have three classifications of individuals. The person A is the confirmed case, and that's no one's disputing that those individuals should be in isolation. Then we have person B, who is identified as a contact of a case. Back in that period of time, a week or so ago, the directive was that those were required to be in mandatory or precautionary quarantine. And then we have person C, who is a contact of a contact. And unless person B has or develops the symptoms of COVID-19 or tests positive for COVID-19, the person C is not subject to quarantine. So I know that all of you are probably inundated with this information, and it is very easy to miss a step in this process, which is why I just want you to put this in the back of your minds for a few minutes until we get to the current day of how some of this has changed. And you'll notice at the bottom of this slide that there are footnotes, and I'm not going to go through those in the interest of time, but it does again define how we define each one of these particular individuals. And then again, probably I'd say all the days kind of blur into themselves, but somewhere around a week ago, or maybe 10 days ago, maybe even a bit longer, DOH released this guidance, okay, which basically said we are recommending that these questions be asked of individuals that are receiving services or to be receiving services, and even to staff. And I know that this in itself, as it relates to patients and even staff, has posed some significant challenges for the home care community, and we'll talk about that a little bit later. But just to review, there were several questions, and basically asking, have you or anyone in the household been tested and confirmed to have COVID-19? Okay, and then it basically tells you what to do. And then if they have not been tested or confirmed, to go to the no answer, and again tells us what to do. And then if you've answered, has a person in the home traveled to a country for which the CDC has issued a level 2 or 3 travel designation in the past 14 days? And have you had contact, close or proximate, with anyone known COVID-19 in the past 14 days? And so they gave us this framework by which to work with. And again, some of it has been changed somewhat, but I wanted to make sure that I showed everybody where we were and where we are today, with a little bit change up in the guidance. So getting back to the patient screening questions. If a face-to-face contact is clinically indicated, okay, prior to conducting face-to-face activities, providers should be asking the participant and or their legal guardian or authorized representative the following. Do you have a fever, cough, or shortness of breath? Ask the participant, have you or someone with whom you've had close physical contact traveled outside the United States within the past 14 days? And if the answer to that is yes, to which countries did you or your contact travel? And ask the participant, additionally, within the last 14 days, have you had contact with any persons that are under investigation, which we've termed PUI, for COVID-19, or with any persons known to have COVID-19? Now, these seem like a pretty straightforward list of questions. However, as we all know, the devil lies in the details. And the mechanism that's used to be able to ask the patients these questions, which I'm hoping we'll be able to discuss in a little bit greater detail and hear from some of you what your practices may have been and what some of the challenges are, as presumably we are doing the best that we can with doing these patient screening questions. So in response to any of the questions, the staff should ensure that the individual is referred to the appropriate healthcare provider and coordinating next steps with their family and healthcare provider, and everything seems extremely logical. But again, I recognize how the devil lies in the details, and oftentimes a healthcare provider is not readily available, a family is not readily available or willing to take responsibility. So recognizing that herein may lie some of the gaps in us as community providers being able to orchestrate these requirements or directives from the Department of Health. Department of Health also strongly recommends that an agency ask screening questions regarding a prospective patient's symptoms and exposure prior to accepting new admissions and referrals for care. The department also recommends that the agency communicate with the local health department where the patient resides to determine if any prospective patients are under mandatory quarantine or precautionary quarantine before providing services to a new patient. And if the novel coronavirus is suspected in staff or patients, immediately notify the local health department. And I did cull this website out from the vast amount of other information. So you would have it readily available because it does show you in each of your locales where and how to contact the local health department. So we all know that our healthcare personnel are critical now more than ever, and we need to ensure their welfare and safety as well, not just for the patients, but for them and for their individual families. So the same questions are to be asked of the healthcare providers. And here we go with some of what has changed in the last few days. If the healthcare provider screens positive to have been exposed to a COVID-19 case in the past 14 days, or has traveled internationally in the past 14 days, the entity may allow, and I'll emphasize that, may allow the healthcare personnel to work if all, and again, I'll emphasize that, the following conditions are met. So the first thing is that if you put that person out to work, the healthcare provider would result in staff shortages that would adversely impact operations of the healthcare facility. So I do believe that that's where it starts. You have to first ask that question. If putting that person out of work, regardless if they want to work or not, would result in staff shortages that would adversely impact operations of the healthcare facility, you could allow them to work provided the following things that I will speak about have also been met. The healthcare provider who have been contacts are asymptomatic contacts of confirmed or suspected cases, and they need to self-monitor twice a day. They need to be checking their temperature and any of the known symptoms for COVID-19. And make sure that they undergo this temperature monitoring and symptom checks at the beginning of each shift and at least every 12 hours. And again, I look at this and it's simple enough to understand. And we oftentimes are placed in a situation where our healthcare providers are on the honor system and we ask them to do this and we assume that they do it. Sometimes there are other reasons why healthcare providers may feel compelled to go to work regardless of what their temperature or symptoms are. So I don't propose to know 100% how to ensure that this is really happening, because the CDC recommends as well that this be self-reported, but recognizing that there are inherent concerns with that as well. HCP who are asymptomatic contacts of confirmed or suspected cases should wear a face mask while working until 14 days after the last high-risk exposure. And HCP who are asymptomatic contacts of confirmed or suspected cases should wear a face mask while working until after 14 days after the last high-risk exposure. To the extent possible, assign home care personnel working under these conditions to patients at lower risk for severe complications. HCP allowed to return to work under these conditions should maintain self-quarantine when not at work. So they're out at work, but they should go immediately at home and follow the recommendations for self-quarantine. If any healthcare personnel who are asymptomatic, an asymptomatic contact develops symptoms that they should immediately stop work and isolate at home. All staff with symptoms consistent with COVID-19 should be managed as if they have this infection, regardless of the availability of test results. So we've heard repeatedly about individuals who have symptoms have been waiting test results, have been out and about, only to find out several days later that they've been positive, thereby putting others at risk. So all staff with symptoms consistent with COVID-19 should be managed as if they have this infection, regardless of the availability of test results. So I want to just talk a little bit about the suitability of providing care in the home. And I've had several conversations with many of the providers in New York. I also spoke to some of them in New Jersey. I spoke to some individuals from HCA because I was really interested in finding out if the home care agencies are actually serving patients that are known cases of COVID-19. And what I've heard pretty loud and clear across the board is that the providers don't have the PPE that is needed to ensure the safety of and welfare of the staff. And for the most part, have not been accepting these cases. But when we open this up to conversation, I'd really like to hear from you what your circumstances are. So when we look at the suitability of providing care in the home, we want to make sure that the residential location is acceptable to begin with. And that opens up a whole cans of worms because we know as home care providers, we don't necessarily control the environments that our patients reside in, and some for various reasons are suboptimal. In consultation with the state or local health department staff, a healthcare professional should assess whether the residential setting is appropriate for home care. And some of the considerations for care at home include whether the patient is stable enough to receive care at home. Appropriate caregivers are available at home. And this is one of them that, you know, oftentimes we don't have caregivers in the home, but we kind of know that patients will be okay. With this illness, what's frightening about it is that the condition of the patient with COVID-19 can change so dramatically. And I think we've all heard a lot of those reports on television and radio that individuals walk into emergency departments and with minutes or sometimes hours go to being alert and oriented to close to respiratory arrest, being sedated, and being on ventilators. And it scares me to think that we would have a COVID-19 patient at home without a caregiver or someone there with them. And if they went bad, because the rate at which the decompensation happens, there might not be suitable assistance to help them. If they're living in quarters where there are others with them, there should be a separate bedroom where the patient can recover without sharing immediate space with others, recognizing that this is often not possible. That there are resources for access to food and other necessities as available, and that the patient and other household members have access to appropriate recommended personal protective equipment, at a minimum gloves and face masks, and are capable of adhering to precautions recommended as part of home care or isolation, including respiratory hygiene, cough etiquette, hand hygiene, etc. There are household members who may be at increased risk of complications from COVID-19, which include those people greater than 65 years old, young children, pregnant women, people who are immunocompromised, or have chronic heart, lung, or kidney conditions. So there are some circumstances where I think we would all agree that it could be safe to care for these individuals in their home, but there are a lot of reasons why it may not be safe. And I know that, not to get into some of the rules as it relates to skilled nursing facilities, but there have been waivers that have eliminated the need for a hospital stay for home care recipients to go into skilled nursing facilities. And again, I'm not suggesting that these individuals go there, but I just want to make sure that everybody is keenly aware of the challenges, and I'm sure you are, of maintaining patients at home during this difficult time. When we're caring for patients with COVID-19, again, we talked about this over and over again, and that word appropriate PPE, including a gown, mask, goggles, and gloves, are kind of the hot term. I know that there seems to be a severe shortage, not just with goggles and gowns and gloves, but with the N95 respirators, which are really the only known presence barrier that can be a relatively 100% or 90 some odd percent against COVID-19. Ensure that the staff know how to don and doff PPE without contaminating themselves. It's great to be able to have the supplies, but if it's not being used properly and placed and removed properly, the risk of contamination is great, and all the efforts used to employ this methodology somehow goes to waste. So I'm hoping that in the absence of staff having been educated on this before, that perhaps there are mechanisms that you have in place, either through videos or something that you can roll through this with staff, so that if they are called into a case, that they do know how to don and doff the PPE. I can't reinforce enough the basic infection control measures, including the hand washing for at least 20 seconds. And Dr. Anthony Fauci and all the other infection control specialists talk about the distancing and the hand washing as the single biggest things that we can all do to prevent the spread of this. Make sure that we continue to use barriers for nursing bags and equipment. This virus stays on those surfaces for a significant amount of time. There's been discrepancies in what those reports have shown, but it's more than just minutes. So we want to make sure that anything that is brought into a patient's home or used as equipment for patients is adequately disinfected, and where possible, keeping equipment in the home that is used solely for that patient. Only use an N95 respirator mask if the patient has a diagnosis that requires airborne precautions. And I'm sure some of you probably at this point are rolling your eyes and saying, oh my goodness, N95 respirators, we should only be lucky enough to have them at our fingertips. But if we are, let's just make sure that we are using them wisely and preserving them for the patients that has a COVID-19 diagnosis. And if the patient has COVID-19, the research is showing that a mask should be placed on the patient, and if possible, the patient placed in a room by him or herself, and keeping the patient isolated as possible. I don't know how many of you have been wearing masks lately, but I could tell you that it's not easy to walk around with a mask on. And if you're a patient and you have compromised respiratory status, as most of these individuals do with COVID-19, I'm not sure, while I understand the importance of it, I'm not sure what the level of tolerance will be for patients. So fast forward, unfortunately, it's not as fast as we're making it out to seem in this presentation, but when we have staff that have been quarantined or have had COVID and they're ready to return to work, we have to make sure that they have maintained isolation for at least 7 days after illness onsets. must have been fever-free for at least 72 hours without the use of fever-reducing medications, and must have other symptoms improving. Okay, so all three of those things need to happen before a confirmed or suspected COVID-19 individual can return to work. If HCP is asymptomatic but tested and found to be positive, they must also maintain isolation for at least 7 days after the date of the positive test. And if they develop symptoms during that time, they must maintain isolation for at least 7 days after the illness onset and must be fever-free for at least 72 hours without fever-reducing medication and with other symptoms improving. Staff that are recovering from COVID-19 should wear a face mask and continue to practice proper hygiene protocols while working until 14 days after onset of illness if the mild symptoms persist but are improving. Again, we mentioned this earlier, assign staff working under these conditions to the lowest acuity patients as possible. The home care personnel, the healthcare personnel should allowed to return to work under these conditions should maintain self-isolation when not at work. So we're seeing here in these regulations the necessity of getting providers back to work, but also limiting their contact with others when not absolutely necessary in the provision of healthcare. Asymptomatic individuals who were confirmed as having COVID-19 may discontinue home isolation when at least 7 days have passed since the date of their first positive COVID-19 diagnostic test and the individual has had no subsequent illness. So a lot to absorb here. Different scenarios for different people at different points of the spectrum, but these have been released recently, and I wanted to make sure that amidst all the many pieces of paper and emails that you receive, you had this in front of you to refer to. Now, there are other recommendations by DOH to prevent spread, and there have been waivers that have been granted, and I'm going to talk specifically about some of those, and some may apply to you and others may not. So physicians that are ordering personal care services and consumer-directed personal assistance services are encouraged to use telephone or permitted telehealth modalities in connection with completion of the required physician order. So they are absolutely looking to eliminate as much patient contact as necessary. And by doing this, they aren't placing a physician or a patient potentially at risk. If it's not critical that the service be provided now, can it be postponed until the risk of COVID-19 is lower? And I think we need to continually ask ourselves that question all day, every day, for every single situation that we deploy staff or patients to. Can the service be done remotely by other mechanisms, phone call, video conference? And I'll just interject at this time that, up until about a month, maybe 4 or 5 weeks ago, the thought of using FaceTime, Skype, any of those modalities to communicate with patients was forbidden as a HIPAA breach. But there has recently been waivers that have been granted by the federal government and CMS that are allowing these things, okay, to be used, knowing that not every provider had the capability of providing a HIPAA compliant telehealth modality. So as long as you're not being reckless, as long as you're limiting the people on the line to those that absolutely are involved in the care and need to know about the patient, these things are now permitted and basically allowed to make the providing care and services and information sharing easier. Some other important updates include, and we talked a little bit about this, initial authorizations for personal care services and consumer directed can be done by the ordering physician using the telephone or permitted telehealth modalities. Registered nurses may conduct initial community health assessments by telephone or permitted telehealth modalities. And again, the permitted telehealth modalities is pretty wide open these days. FaceTime, Zoom, Skype, basically any of those things that help connect individuals face to face. New York State Department of Health has suspended all required periodic reassessments through Medicaid managed care, including MLTC or fee-for-service Medicaid. And the 6-month in-person care management home visit requirement is suspended as well. Any related home visits due but not conducted under this suspension should be noted in the plan of care and care management record for audit purposes. So the purpose of that is so the regulators realize that you were not able to do it because of this situation and that you just didn't forget about it or didn't care about it. So make sure you do note this in the plan of care and in the care management record in case you are questioned at a later time. Immediate suspension of annual renewal of health assessments for employees, immunizations, and TB test personal assistance providing services to consumers in the CDPAP program, 100% work from home for all non-essential personnel. And I know that over the past few weeks since that mandate came out by Mayor de Blasio, there's been some ongoing discussion over what's essential and what's non-essential. And providers need to determine that based on their individual circumstances. Nursing supervision visits for personal care services provided to individuals affected by the disaster emergency should be made as soon as practicable, okay? And I wrote in there, emphasis added, in place of requirements for such visits to be made at least every 90 days. So we don't know when this is over, okay? And as soon as practicable could mean in 2 months, and it could mean in 6 months, or I don't even want to think beyond that. To the extent necessary to permit certified home health agencies, and I know we don't have a lot of certified home health agencies on the phone, but there are some long-term home health care programs, AIDS home care programs, and licensed home care services agencies serving individuals affected by the disaster emergency to conduct in-home supervision of home health aides and personal care aides as soon as practicable. And again, I'll add emphasis to that, after the initial service visit, or to permit in-person and in-home supervision to be conducted through indirect means, including by telephone or video communication. And to my LICSA colleagues, I want to point out that, this is also looking to reduce the amount of personal contact that CHA personnel have with aides. And I would just ask that, knowing that it's conceivable that we may not have in-person home health aide supervisions, that you continue to work with us to ensure that the aides have the support and the knowledge and the reinforcement that's needed for them to do what they need to do with the patients that they serve. As Governor Cuomo continues to say, we're in this together. There's no division between licensed and certified. We're in this together. We're serving the same patients, and we need to help reinforce for one another. CMS is fully aware of a scarcity of PPE supplies, And the state and federal surveyors have been advised and instructed not to cite providers for not having certain supplies. However, logs need to be kept to show efforts employed to secure supplies. So if you keep contacting your local officials, or if you're hospital-based, your procurement departments, or whoever you reach out to, or your suppliers, you contact them repeatedly for the purpose of procuring these supplies, and you're not able to get them, you should be keeping a log to show your efforts. This, I believe, will also be helpful when going back and looking at this information in the future, so we perhaps can be better prepared next time, although I hope there never is a next time. Another very interesting development to allow registered nurses, licensed practical nurses, and nurse practitioners licensed and in current good standing in any state in the United States to practice in New York State without civil or criminal penalty related to lack of licensure. I don't believe that up until this point that New York or New Jersey were compact states, so they did not recognize licensure of these professionals from a different state. But now it doesn't matter if you're licensed and in good standing in another state in this country, you can come to work in New York. And we saw, probably many of us saw that Southwest flight that was headed to JFK the other day with a whole slew of healthcare providers that were coming from other parts of the country to help us. For the LICSAs, extend the time in which home care services entities must submit information to the home care worker registry. And CMS is also waiving the 14-day on-site supervision of home health aides. The virtual supervision, again, is encouraged. Standard home health and hospice recertification surveys and revisit surveys should not be conducted until further notice. I'd be interested in hearing if any of you have had the state appear at your offices, because they should not be doing surveys. We don't have the time and personnel to be diverted with other activities that are not directly related to the care of patients. For those that are fortunate enough to have N95 FIS-tested employees, OSHA has temporarily removed the requirement for annual fit testing. Initial fit testing is still required though. Okay, so if you have staff that have N95 respirators, they can continue to use them without being FIS tested. But if you're getting new N95s and fitting other staff, they do need to be fit tested to ensure that they fit directly and are doing what they're supposed to be doing. I talked earlier about the links that I kind of put together for everybody. Each one of these sites has a million other links, but these are most focused on home health and community-based care. So I'm sure that we could send the presentation out to everybody later, and if you just click on any of this, you'll go to those sites. I hope that everyone has found this helpful and useful. And I also hope you know that we at Audacia are totally committed to helping you through this crisis and want to be an extension of your team to help get you information, advocate on your behalf, and or be there to just listen. You are welcome to enter questions in the chat box and we will do our best to answer them. We have a hard stop at 12:30, but we have about 15 minutes, or you may also send questions at any time related to COVID to the COVID response at audaciafoundation.org. Thank you for your time, and hoping that we are able to weather the storm, and as we normally do, generally come out better than we were before. Thank you.
Thank you, Anne. Really appreciate you being able to take all of the different regulations and information coming to us from different sources and, synthesizing it in a way that's comprehensive and yet easy to understand for everyone. We do have a couple of questions that were submitted. Please feel free if you have others to do so. It might have been answered by the presentation earlier on. The questions came in some soon after we started, but we'll restate them again. First question, should aides wear surgical masks or N95 masks when taking care of a positive coronavirus patient? Do they have to wear gowns too? Mm-hmm. And then there's another question after that. What do we do if the aide does not have a thermometer to self-test temperature?
You're referring to self-testing of themselves, I imagine.
Yes.
Okay. So based on the guidance from the CDC and from Department of Health, aides that are taking care of COVID positive patients should be wearing N95 respirators. Now, I would also refer you to your own individual policies and procedures as they relate to infection control. But this is, the N95 is designed to prevent the spread. The other masks I can't speak to because there's so many different ones available. People are coming up with makeshift masks, and people are buying masks on the black market, and there's, anything and everything. The N95s, and they showed the other day how you need to look inside the N95 to see that it's an approved N95 mask, but they should be wearing those. If you don't have N95 respirators and you are inclined to send people into the homes of patients that have been confirmed COVID cases, I would contact your local health department and make them aware of it and ask for their assistance.
Okay, thank you. And what about can we address the aide not having a thermometer? Even I would say I would expand on that, not just for self-testing, but also what if the client doesn't have a thermometer?
Right. Depending on the resources of the organization, perhaps they could purchase a thermometer for a patient. We often do that in home care. We actually give thermometers to patients when we admit them. So if the person is receiving certified home care, I know that a lot of the certified agencies they don't want to use the same thermometer over and over, or they use the strips and they leave them in the home. I would suggest that. See if there's a family member or a friend available to purchase a thermometer. It doesn't have to be an expensive thermometer. It could be one of the small digital thermometers that are not particularly expensive. And for the aides, I would again recommend that where possible, the agency provide them with this equipment, because in my mind, this is part of their PPE. This is part of their personal protective equipment, which we are required to provide for aides. And they can't go out there and ensure that they're protecting themselves or protecting others if they don't screen themselves for COVID. And one of the major things, although not 100%, because apparently, which makes this whole thing so difficult, not every patient that has contracted COVID has had a fever, but the lion's share of them have. So I know that we are all faced with so many unfunded mandates and the margins are just shrinking away. And this is just one more thing, but I think we need to think beyond that for the long term. And right now, it's about how we're going to best protect our patients and how we're going to protect our staff.
Okay, great. Second question is a very good one. It relates to CDPAP. And the question is, I'm aware that we are required to call our patients and home health aides and screen them for COVID. Is this also a requirement in the CDPAP program? And what happens if furloughs have limited the resources to make the calls?
Okay, you know, a good point. And again, you know, if we don't screen the patients, we're going to send people to the home that are potentially going to be exposed, and we're going to further decrease our resources. So somehow we need to figure out a way that we can make those calls. And again, I know, you know, in my experience that sometimes the local health departments are not as accessible or available or helpful as they would like them to be. But I would reach out to them and let them know the dilemma, and see if there's any resources that they might be able to provide to help. You know, we have a lot of people that are at home right now working. Some are busier than normal. Others may not be as busy as they normally are. And perhaps we're able to reassign that responsibility to someone else to do the screening. None of this is ideal. And I don't tend to be a person that promotes mediocrity. Those of you that know me, I don't promote mediocrity, but in some of these situations, even the directive from the DOH has been, we just have to do the best that we can, knowing the risks inherent and deciding where best to use our resources.
Okay, wonderful. Well, thank you for taking these questions. I don't have any other questions at this time. We can, as we said, unmute the call if anybody would like to make any comments or share anything with us. We'd like to do that now to give people that opportunity.
I guess I'm going to just throw a question out there.
Sure.
Have many of you been able to admit COVID-19 patients with following the stipulations that have been advised by the DOH? Is that like a no?
So we encourage everyone to reach out to us independently of this call. And share any thoughts with us. We have a question. Are there any relaxations of hiring aides for LICSAs, specifically the medicals, fingerprints? Has there been any relaxation of those standards?
Yeah, I have not seen that, but that is a question that I will take for follow-up so that I can get back to the group in terms of what the answer to that is. And I can appreciate, Christian, why you're asking that question. because if you need to bring in people to work, we don't necessarily have a whole lot of time to go through that whole process. So let me take that, and I will get an answer out to all of our participants about that in the next few days.
Thank you.
Thank you.
Anyone
Thank
have
you.
anything else that they'd like to share? Anything that you're doing as an organization that you think would be helpful to our colleagues?
Just one more question, please.
Sure.
With regard to, and I don't know if you answered this already, the using FaceTime or Skype for Alexa for a standard 3 or 6 month visit.
Mm-hmm. Yes, you can
If that's the most practicable way for the RN to do a standard nurse visit, is that acceptable? And the same thing for a new patient assessment?
Absolutely. Where there are situations where it would be risky related to COVID-19, you are permitted to use any of these modalities, whether it be just the telephone, whether it be Skype, whether it be FaceTime. I don't know if some Androids have the similar capability or whatever. You can use those. But again, I just want to highlight that although there's kind of been a waiver granted about that, and that those aren't considered HIPAA breaches because they're technically not secure, that you can't be reckless with it. Okay, you know, you don't want to do that in the middle of your living room. Okay.
No, I get that.
Okay.
But my question is, for a new patient also, like sight unseen, I can just do a Zoom.
Yep. Mm-hmm.
Okay, and can you direct me to where that is? Where can I find that?
The actual verbiage.
Yeah.
Okay, I will send that out to you. I have a stack of papers here, but let me cull through it all, and I will send the reference out to you.
Okay. Should I send you my email address?
Well, I see this is Christian speaking.
Yeah.
I'm going to send it out. Anybody who's on this call will get the answers to any of the questions that are asked. So it will go out to the group.
And I was told that there's a place where the Office of Emergency Management could give us supplies. Do you know if that's true?
Well, that's what I've heard. Okay.
Right.
And a lot of the directives have been around contacting your local Office of Emergency Management. But what is said and what is done sometimes are disconnected. Mm-hmm. So I would encourage you to call there and to find out, and also to let them know what your situation is and how desperate you are to be able to continue to fulfill your requirements as an organization and to serve people that are ill.
Right. And I don't even know what the number is, the Office of Emergency Management. How would I get that?
What location are you in? Are you in Manhattan or?
Yeah, Manhattan.
I don't know, but I will definitely look it up for you.
Oh God, thank you so much.
That's okay. Yes, that's why we want to be here to be a resource, so you can do the stuff that really matters on the front line, and we can help you in the back, so you don't have to spend countless hours.
Thank you so much.
Yes, I just wanted to reaffirm what Ann said, that we did hear this morning on an earlier call that the city Department of Health, along with Emergency Management, is working to facilitate providing supplies to home care providers. As you know, it's expected that they be able to take the convalescing COVID positive individuals, and so they realize that they have to, in limited supplies, and supplies are going out steadily. There is, on the nursing home side, we know that they are replenishing supplies. I mean, we know what we're all hearing on the media. It is strained. It's not the amount, the quantity that everybody would like, but there are supplies, they're being rationed.
Sure.
And so we did hear this morning that home care is being included in that, in those, delivery slots.
Is that online, or is there, like, how do I get
No.
in the know about this stuff?
Right. So let me get you the contact, because
Gotcha.
there's a form. There's a process that you have to go through. So
Right.
let us find that out for you, and we'll share that with the group. We'll also
And Effie,
share.
I have that as a note to follow up.
Okay, great.
Okay.
And in addition to answering any questions we didn't today, we'll also be able to, we'll share with everyone the PowerPoint, and, hope to be able to continue as developments change, reach out to all of you and encourage you to stay in touch with us as well.
Very helpful. Thank you so much.
Okay.
Well, if there aren't,
I see that Arthur asked a question, can you share where to obtain PPE like gowns and N95 and goggles? I think at this particular time, you're probably best bet is by going to the Office of Emergency Management and the City Department of Health, and we will be sending out that contact information. Also, for those of you that maybe don't reach out to HCP or HCA, if you're members, they have been a really tremendous resource. And rather than trying to cull through tons of information, if you just send them a note, they can get you information sometimes a lot quicker than you would find it. But these questions we're definitely going to take and get you answers to. In addition, the COVID response email address that we publicize on the screen now is available. So as you move forward today, tomorrow, next week, next month, if anything else comes up, we encourage you to put your question in there. No question is too stupid. And by you asking the question, it helps a lot of other people in the process.
Absolutely. Well, I want to thank everyone for joining today.
Thank you.
Again, we really can't begin to even recognize the tremendous burdens that are on healthcare providers, collectively, agencies, your workforce. We want to let you know that we are thinking of all of you, and really want to be support to you in any capacity that we can. So again, please reach out to us with questions. We'll do the best we can to get you the resources and any assistance we can. And thank you, Anne. I want to thank Anne also for joining us today and participating. And everyone have a good day and be safe. Thank you.
Thank you.
Okay. Thanks, everyone. Take care.
Thanks.
Bye-bye.